Good afternoon all. The next CCR is from the ENT department. So we are presenting a case of head and neck mucormycosis. It's not entirely managed by our department because it was done as a multidisciplinary approach and we could manage it successfully. And the department involved were infectious ID, microbiology, pathology, pediatrics, radiodiagnosis, and lastly, for the rehabilitation part, we took the help from prosthodontics. So, Dr. We start from Dr. Mahesh will be presenting and Dr. Prem Sagar will be discussing.
Thank you, sir. Good afternoon, everyone. So it's a 10-year-old male kid presented to the pediatric casualty on 15th May with the complaints of left-sided cheek swelling along with the left-sided vision loss. So he had a dental pain that started 12 days back, for which he underwent tooth extraction from the nearby hospital, which was not documented. 3 days later, he developed a swelling over the left cheek region, which was painful and which was rapidly progressive over the next 8 days, with the associated high-grade intermittent fever with chills and dryness with reduced oral intake as well. He had developed a left eye swelling which progressed over the next 6 days, and he developed no perception of light from the normal vision over the period of 6 days. Later, he developed a reduced mouth opening, which was rapidly progressive, with no prior history of any headache or nasal obstruction or nasal discharge. So the patient was febrile on examination. He had tachycardia as well as pallor noted on examination. On neck examination, multiple tender firm nodes noted in the level 1B and the level 2 region with a maximum of 3 into 3 centimeter size noted in the left level 2 region. Over the cheek, about 5 into 6 centimeter of fluctuant tender inflamed swelling noted. On the oral cavity examination, bulge noted in the left tonsillar fossa region and the oropharynx region, and whitids candidiatic lesions noted over the buccal mucosa as well as over the tongue. On further examination, eye evaluation, axial proptosis was noted with the chemosis and extensive crusting noted over the left cornea. Left eye ptosis noted. Pupils were fixed and dilated and globe fixed as well. Right eye vision as well as extraocular movements were within normal limits. Fiber optic laryngoscopy done, which revealed candidiatic lesion were extending over the oropharynx as well, base of tongue and valvula, though the larynx is free. Now I call Dr. Kaushik to discuss the radiology finding of the same case on presentation. It's clear that, but it's not clear.
So this is the initial scan that was at presentation. Here we can see in the axial sections there is involvement of the left orbit. Both the intracorneal as well as the extracorneal fat and the intraocular muscles are involved with thickening and fat stranding. There is some enhancement in, surrounding the optic nerve sheath as well. And there is a classic guitar pick sign. This with proptosis, this occurs when there is raised intraorbital pressure. So apart from this, there is a ill-defined abscess connection that we can see in the along the left temporal fossa. The cavernous sinuses are normal and normally enhancing. The connection is also seen in the bilateral infratemporal fossa as well as in the left premaxillary area. Bilateral parapharyngeal spaces are also involved, and there is a collection in the left mesenteric space as well. So in the coronal images also, we can see that the bilateral parapharyngeal spaces, there is a large air-containing collection that we can see on the left side with soft tissue thickening on the right. And in this coronal section, we can see that there is involvement of the intraocular muscles as well as the intraocular fat and extensive deep neck space infection, predominantly along the left side of the neck. However, there is no bony involvement and no involvement of the capillary sinuses at this time point.
So, based on the clinical radiological evaluation, diagnosis of deep neck space abscess following dental extraction made, and the patient was subsequently admitted for the IV antibiotics and urgent surgical drainage. So he underwent bilateral intraoral drainage of the abscess and the left transcervical approach drainage of the abscess and the left medial orbital debridement, followed by elective tracheostomy to secure the airway under general anesthesia on 17th March 2023. So we can see the masticator space and the parapharyngeal space in the picture on by both sides, as well as the buccal space on both sides, the buccal size both sides. Intraoperatively, around 50 ml of pullens from the left parapharyngeal space and masticator space drained, as well as from the infratemporal fossa drained. Right parapharyngeal space, the fat was found to be unhealthy, which was debrided. Partial necrosis of the left masticator as well as the masticator as well as the medial pterygoid muscle was noted, which was debrided. In the left side medial orbit, Lynch incision given and unhealthy medial neck orbital fat was debrided also. So the overall debridement contained the right parapharyngeal space debridement along with the left parapharyngeal space, left masticator space, as well as the infratemporal fossa debridement on the first surgery. Post-operatively, KOH mount showed broad aseptate hyphae, which was suggestive of mucormycosis. Based on the evidence, he was started on intravenous liposomal amphotericin B. He didn't have any known comorbidities, so he was evaluated for the underlying immunocompromised conditions as well. Post-operatively, the bacterial culture revealed Escherichia coli, and based on the sensitivity reports, he was started on the injection, piptas and the injection, meropenem as well. The histopathological report confirmed the diagnosis of mucormycosis, and the patient was continued with the antifungals as well. So now the diagnosis of rhino-orbital invasive mucormycosis with the deep neck space abscess involvement with the concomitant bacterial infection was made, and the patient was treated with the antifungals as well as the antibiotic therapy. We don't know what was the underlying immune compromised condition which led to the condition. So he was evaluated extensively for the same as well. Now I call Dr. Jayashree to for the immunological workup.
Good afternoon. Now, moving on to the risk factors for mucormycosis in pediatrics. The most common associated risk factor in pediatric population for mucormycosis is hematological malignancies, and acute leukemia has been found to be associated with mucor, followed by aplastic anemia. And 10 to 30% of pediatric mucor cases occur in children with diabetes. And apart from that, we have other risk factors like iron overload and deferoxamine therapy. And burns and traumatic wounds are associated with cutaneous mucor. Mucormycosis is not typically associated with any form of primary immunodeficiency. In newborn, prematurity is a significant risk factor in neonates for gastrointestinal and cutaneous mucormycosis. So, in our patient, we worked up for diabetes. We did a peripheral smear to rule out any hematological malignancies. We did autoimmune workup and viral markers, but still literature shows that 9 to 10% of the mucor cases have no identifiable cause. So just a few differences between pediatric and adult mucormycosis. As we saw earlier, in pediatrics, prematurity and leukemia is the most important factor compared to diabetes, but in adult population, uncontrolled diabetes is the most important risk factor. In both groups, rhino-orbital involvement is most common, but pediatric population, they are more prone to get gastrointestinal mucormycosis and cutaneous mucormycosis. And in pediatric mucormycosis, the mortality rate is a bit lower, like it's as low as 3%, and some studies have reported 60 to 50 to 60%. And in adult mucormycosis, the mortality rate is 28 to 52%. So, now coming to this patient, the challenges faced in the treatment of this patient was the initial presentation was with high grade fever, and the patient had multiple abscesses, and it was not so typical of mucormycosis. And the patient underwent multiple surgical procedures, and therefore had prolonged hospital stay and an increased risk of infection. As we saw earlier, he also acquired secondary MDR nosocomial infections, which had to be treated with antibiotics. And since we were giving both antibiotics and antifungals, there were increased risk of drug-drug interactions and adverse effects, and the patient obviously needed a prolonged course of treatment. So, just a very brief outline about primary immunodeficiency disorder. So, when to suspect primary immunodeficiency disorder is that if the infection is at an unusual site by an unusual organism like pneumocystis or fungi like aspergillus and nocardia or serratia, and if the severity is unusually high, or and if the patient has more than one systemic bacterial infection in the form of sepsis, meningitis, pneumonia, or if the patient has more than two serious respiratory or bacterial infections in past 1 year, like cellulitis, osteomyelitis, abscess, or pneumonia, and so basically, we can divide the approach to PID in three groups. First will be the routine usual investigations, complete blood count in the patient, and second, depending on the type, the defect we are thinking, whether it's a B cell defect or a T cell defect or a phagocytic defect or a complement mediated defect, we can perform screening tests for a specific group that is involved. And once we are getting any positive tests in screening, we can try advanced genetic testings like whole genome sequencing for the patient.
Thank you, ma'am. Despite all these interventions, patient continues to have a high-grade fever episodes. He had a residual disease as well. He had a left artery disease in the form of pus-filled necrotic orbit, as well as the active discharge was noted from the intraoral wound as well as the transoral wound. So he underwent a left endoscopic debridement and along with the left arterial extension and the debridement of the bilateral masticator space and left infratemporal fossa under general anesthesia on 31st May 2023. Intraoperatively, around 7 to ml of pus drained from the infratemporal fossa and pterygoid space. Necrotic medial pterygoid muscle was debrided. 5 ml of pus was drained from the masticator space and necrotic masseter muscle also debrided. Pus-filled necrotic orbit completely excentrated and post-mites found to be unhealthy and necrotic, which were debrided. Post surgery also, patient continue to experience the febrile episodes high grade. So we did the pyrexia workup to rule out the other causes of other possible causes of fever. So all those investigation came negative, and we thought somewhere the residual disease was left to begin. That's why he is experiencing the fever episodes. So patient underwent contrast CT of paranasal sinus, which showed the reformation of abscess in the right masticator space, for which he underwent the right transapical abscess drainage under GA on 17th June 2023. So where the pus packet was localized in the right masticator space, which was drained and unhealthy tissues were debrided. Post-operative culture showed Escherichia coli and Acinetobacter baumannii. So according to the sensitivity reports, he was given injection colistin, injection teicoplanin, and injection metrogyl. Despite all these interventions, patient continues to have fever episodes and no underlying immunodeficiency disorders detected till now. And he had received 3,750 mg of liposomal amphotericin B, and he was on injection colistin, teicoplanin, and metrogyl as well. So again, CECT face and neck repeated, which showed osteomyelitis of the mandible, sphenoid, pterygoids, as well as the necrotic lymph nodes in the level 1B and level 2 region, for which he underwent a left transcervical approach debridement under GA. And intraoperatively, we noted a necrotic tissues and with the abscess in the left level 2, level 3 and level 5 regions, along with the necrosis, necrotic tissues over the pterygopalatine fossa and infratemporal fossa, which were again debrided. The osteomyelitic mandible was noted along with incomplete fracture, which was not debrided, keeping the severity of morbidity in the mind. Post-operatively, again the culture sensitivity report showed Acinetobacter baumannii and Escherichia coli, and he was given tablet linezolid along with the injection colistin, metrogel, and teicoplanin. So he has received this many antibiotics or the during the hospital course along with the mentioned duration, along with the 5 gram of liposomal amphotericin B, and he was started on a tablet posaconazole 100 mg thrice daily since 9th July 2023, which was continued after discharge for a period of 3 months, along with the monitoring of the therapeutic monitoring of the posaconazole levels. More than one signifies the significant levels of drug in the serum. So he was hospitalized for a duration of 78 days and discharged on 1st August on 100 tablet posaconazole 100 mg thrice daily, which was continued for 3 months, and tablet linezolid 300 mg BD, which was continued for a period of 6 weeks. Post-operatively, he showed improvement, and there was no progression of disease, and purulence gradually settled. So he was again admitted on 28th September 2023 for the decannulation. So he was followed for more than a year, from August 2023 to September 2024, where there was clinically no evidence of disease. So we repeated CECT brain PNS orbit on the 21st September, which didn't reveal any significant residual disease. Dr. Kaushik, please come and discuss the radiology.
So this scan was done when the patient had developed the skull-base osteomyelitis. This was done on 18th of July 2020. Here we can see, as compared to the initial scan, there is involvement of the bone now. There is involvement of the body of sphenoid, the greater ring of sphenoid, as well as the left mastoid. And bilateral pterygoid plates, and there is involvement of the left ramus of the mandible and the inferior and lateral wall of the orbit, along with the thrombosis of the left IJV. This is the right IJV. The left IJV is not seen, and the sigmoid sinus is attenuated. So this was the picture after the progression, but finally, in the follow-up period, we can see from 18 July 23 to the most recent scan, that is September of 24, there is significant resolution of the skull-base osteomyelitis in the anterior and mid skull base that had developed initially, as well as the resolution of the soft tissue thickening that we had seen in the initial scan. The left post-acceleration. So in the recent scan on 21st of September, there is a complete resolution of the disease.
Thank you, sir. So now he is disease free, but his quality of life is severely impaired following the arterial extension. He no longer attends the school, as well as he didn't engage in play with his peer age group as well. The social impact of the surgery has reduced his interactions with in the normal activities, which led to the social isolation. So he was planned for the ocular rehabilitation, but patient had a 3rd, 4th, 6th, and 7th cranial palsy with the lack of eyelid movement. So in this scenario, spectacle attached ocular process is the best cosmetically appealing option. For the same, he was referred to the prosthodontics for ocular rehabilitation. Rehabilitation part will be discussed by Dr. Shairish from prosthodontics.
Good afternoon, everyone. So this was the condition of the patient when he was brought to our department. On local examination, it was found that the lesion was well healed, well circumscribed by the bone. and it was not extending up to the movable skin of the nose or the cheek. So for this particular case, the acrylic prosthesis was considered. For the impression making, first we have made the markings. First, one in the midline, then in the medial canthus of the eye, in the center of iris, and the lateral canthus of eye. And then these markings were transferred to the normal eye. First, these were first these markings were made on the normal eye, and then these were transferred to the contralateral eye. Similar markings after impression, these were transferred to the models. This will later help us to position the iris. These iris shells, these are available in the market, and according to the shade of the iris of the contralateral eye, these shells are selected, and then these are carved in the wax pattern according to the anatomy of the contralateral eye. Then these, to create a mold, these are flashed in the plaster of Paris material, and then after dewaxing, we get a mold. Then in the mold, after shade matching, acrylic is available mostly in the clear. It is clear, so we have to match the shade of the patient. And after shade matching, this material is packed in the mold created. This is the final prosthesis which we got after curing, and then we attach it with the spectacle with the help of screws.
Thank you, ma'am. So, comprehensive management of coming to the mucormycosis. Comprehensive management of mucormycosis includes a prompt diagnosis along with the optimization of underlying comorbid conditions, aggressive surgical debridement of the non-viable tissues to facilitate the drug entry to the viable tissues, and systemic antifungal therapy. So, there was study which was done in our institute which prognosticated the sino-nasal mucormycosis, which was published in 2022, as well as the study by Francis et al., which was on the titled mucormycosis in children, review and recommendations for management. There is a huge difference between the adult as well as the pediatric patients. Adult patients, the uncontrolled diabetes was the most common underlying comorbid disorder, as well as chronic kidney disease, hematological malignancies, or organ transplant, as well as chronic steroid use. As compared to the pediatric patients, where hematological malignancies, more than 90% of mucormycosis cases seen in the hematological malignancies, 1 to 2% of hematological patients have a prevalence to develop the mucormycosis as well. As compared to the diabetes and other immune deficient conditions. Symptomatology, fevers occurs in 93% of pediatric patients, though it's a non-specific symptom, which is usually rare in an adult patient. So localized symptoms are generally not evident until the disease is progressed. So extensive disease is seen in the pediatric population, whereas localized symptoms are noticed early in the adult population. The disease extension also limited. So pediatric patients, most common will be the rhino-orbitocerebral case as compared to the adult population, where the rhino-orbital is the commonest. Mortality, it's around 29% in adult patients as compared to the pediatric patients, where the mortality can be up to 60%. One more entity which is relevant to this case will be the nosocomial mucormycosis. So those patients with immunosuppression by a prolonged steroid therapy, solid organ transplant, malignancies, diabetes mellitus, neonates are at high risk of this nosocomial mucormycosis, which carries a mortality of around 50%. Whenever there is 2 or more invasive mucormycosis by the same organism, same species, within 6 months of admission in an institute, we have to suspect these kind of thing also. So common source of infection should be ruled out in the form of formal air sampling and testing, adhesive tapes, wooden tongue depressors, ostomy bags, hospital line, ventilatory systems, construction site. These are the possible contamination sources to be ruled out in the case of nosocomial mucormycosis. This is the picture at the presentation, and picture during the hospital course and a picture post rehabilitation. Thank you.
Thank you, Dr. Mahesh. Good afternoon, all. So we presented this case because we had a long follow-up of this case where the diagnosis and the presentation are not very classic, very atypical. Sorry for the last slide where he has described the adult and pediatric symptomatology in a different manner. So basically, as compared to other symptoms, other conditions, commonly when there is no comorbid illnesses, the patients usually present with sinonasal pathology, whereas this patient presented following dental extraction. So there was contamination through that surgical site only. So the disease from there involved the parapharyngeal space and the infratemporal fossa, along with bacterial infection. So it spread hematogenously to affect the other side and lymph nodes as well. So, and after the confirmation of mucormycosis by pathology and microbiology, the child did not respond to the usual course of antifungals and antibiotics. So, we stepped up the antibiotics and antifungals and we debrided multiple times so that we do not leave any non-viable tissues where the infiltration or the reach of the antifungals may not be there because the tissues get necrosed when they are involved by mucor. In the last surgery, when we debrided, we saw that from the orbit till the cervical incision, the whole of the tissue beneath the skin flap are all necrosed. But we could not debride the or lateral orbital wall or the zygoma or the mandible because the patient that would lead to significant morbidity and reconstruction at the particular point of time when the patient is still not cured of the disease. However, with long duration of antifungals, everything was taken care of. So the osteomyelitic component also improved. And with the help of the Department of Prosthodontics, we also could rehabilitate the child by giving ocular prosthesis. Thank you. So any further discussion or queries are welcome.
So immediately we saw in the slide mortality rates 50-60%. Now we have to look at two things. All the setup is mostly decay of and this is not attributable mortality. So patient malignancy, treatment, also else many cause this is not true attributable to mortality due to mucormycosis. This is all about mortality most of the time. And subsequently, last 5 years, things at the management of this patient have changed after eliminating the oral drugs. That is formulation, and this is in India also, isopronazole is off patent. So, nearly the same price as going on. Direct automatic, many of the times, because these patients after surgery, you got accuracy for weeks, if not months. Many times they were waiting, not getting tests. Those were affecting the outcome. But now it is much more lean management, good surgery, obviously, ENT does. Unfortunately, a couple of weeks, you realize, and then put on was sorry, so treatment outcomes, I would say currently, obviously, patients in having good care, pulmonary mucormycosis for one, still has a high mortality. But overall, with the improved availability of members, outcomes are much.
Thank you, Dr. Manish. the Kavya sir, if you want to say something.
It was really a challenging, very difficult way.
Yes, sir.
And you can see it can happen in a person, and we have experience with it. When they were given a very high for the AIIMS, and then they were winter. And in this time, look at what into the system. All here networks was the vascular involvement, and then which was equalized and escape factor, which was secondary. And that's why the treatment is significant debridement along
Thank you, sir. So, any other queries? Thank you all. Thank you for joining us.